Welcome back, everyone, to another explainer here on Decode Healthcare with Harshal. We are officially on part 42 of our 100-part ICD-10 CM guideline series. Now, if you were hanging out with us for part 41, you know we completely locked down those dominance rules for hemiplegia. But today, we're shifting gears. We have a massive mission ahead of us. We are diving into section IC6B, which is the section that lays down the absolute strict laws of category G89 pain coding. We're going to figure out exactly how to sequence these pain codes perfectly, and spoiler alert, it depends entirely on the true clinical goal of the patient's visit.
And that brings us right to the golden question, the one every single medical coder faces when they first open up a chart. Is pain the principal diagnosis? I know, it sounds super simple, right? But the answer to that one little question completely dictates whether a pain code grabs that primary, first listed slot on a claim, or if it just gets kicked down the line to act as a secondary descriptor. Getting this wrong doesn't just muddy up the clinical picture, it literally triggers audit failures. So figuring out the true clinical goal of the visit is absolutely crucial. It's the key that unlocks the exact right sequence.
All right, let's quickly hit our roadmap for today. We'll be covering the category G89 pain guidelines, the golden sequencing rule, what to do when treating the underlying condition, navigating postoperative pain, the difference between chronic pain and chronic pain syndrome, and then we'll wrap up by mastering pain code sequencing.
Okay, let's jump right into section 1, the category G89 pain guidelines, and establish our baseline.
So category G89 is our designated home for acute, chronic, and neoplasm-related pain that just isn't classified anywhere else. But before we even think about looking at a single code, we need to get one fundamental truth straight. Textbooks, like Buck's Step by Step, they are fantastic learning tools for sure, but they are not the law. The CMS official guidelines strictly override textbook advice, period. Section I.6b is the ultimate authority here. If CMS and a textbook disagree on something, CMS wins, every single time.
Moving on to section 2, let's talk about the golden sequencing rule and exactly when pain takes that principal slot.
This is where the rubber meets the road. Step 1 is all about identifying the exact reason for the visit. Is the patient at the hospital or clinic purely for pain control? We're talking about things like a nerve block or maybe the insertion of a neurostimulator. If the answer is yes, we hit step 2, where you sequence that category G89 code first. Then, in step 3, the underlying cause of that pain gets slotted in second.
Let's actually visualize the swap in action. Imagine a patient comes in with a displaced intervertebral disc, but today's encounter is explicitly a pain control clinic visit for a steroid injection. Because pain management is the absolute goal today, G89.29 for chronic pain takes the throne right there on line 1. The lumbar disc herniation, that gets bumped down to line 2.
All right, section 3, treating the underlying condition and what happens when the root cause leads.
Let's look at the flip side of that last scenario. What if the encounter is for a procedure that's physically treating the underlying condition? Let's say the patient is on the operating table for a spinal fusion to literally fix that herniated disc. In this case, the CMS guidelines completely flip the script. The lumbar disc herniation code locks firmly into slot 1. You only add a G89 pain code as a secondary descriptor if it provides some extra necessary context. So, the rule of thumb here is if you are treating the cause leads.
Next up, section 4, navigating postoperative pain and figuring out what's routine versus what's a complication.
Listen up because this right here is a massive high-risk audit area. First rule of post-op pain. Routine, expected postoperative pain gets a giant red strike through. You just do not code it. Normal post-surgical soreness is entirely excluded from the claim because, well, it's already bundled into the surgical package. Second rule. If post-op pain is documented but the provider doesn't bother to specify if it's acute or chronic, your default is always going to be acute. And finally, you only assign those specific G89 codes, like G89.18, when the pain is explicitly documented as a true complication, like, say, painfully infected wire sutures.
Moving right into section 5, chronic pain versus syndrome, and the absolute need for precision in your documentation.
We really need to unpack a critical distinction here, because mixing this up leads straight to audit rejections. Chronic pain syndrome, which is coded as G89.4, is a totally distinct clinical entity. It's not just, pain that a patient has had for a really long time. It actually involves complex physical and psychological impacts. Because of that heavy clinical weight, CMS mandates that you can only code it when the provider has explicitly written the exact words chronic pain syndrome.
So, think about the two diagnostic paths here. On one hand, if the provider writes chronic pain, you assign G89.29. But on the other hand, if they write chronic pain syndrome, you assign G89.4. You absolutely cannot substitute one for the other. You can't just look at a chart, see a patient who's been hurting for 5 years, and kind of assume it's a syndrome. Nope, no way. That is a one-way ticket to a denied claim. The precise wording the provider uses dictates your path.
Finally, Section 6, Mastering Pain Code Sequencing, with our mental cheat sheet.
To bring all this CMS guideline data together, we've got the ultimate cheat sheet for you to sequence these flawlessly. Think about the flow. If the encounter is for pain control, G89 takes slot 1. If the encounter is to treat the underlying cause, that root cause takes slot 1. And if the encounter just reveals routine post-op pain, you don't even code it.
So, the absolute most vital takeaway from section IC6B is simply this. Coders cannot assume, ever. You can never assume there's a correlation between a surgery and a pain complication, and you can never, ever assume that chronic pain equals chronic pain syndrome. The provider's explicit, specific wording has to be the only thing guiding your code assignment.
And that pretty much wraps up our deep dive into category G89. If this explainer helped clarify pain sequencing for you, definitely make sure to subscribe, hit that like button, and share it with your fellow coders. And hey, you're not going to want to miss our next explainer, part 43. We are moving into chapter 7 to tackle section IC7A, covering glaucoma staging and bilateral glaucoma rules.
I'll leave you with this final thought before your next shift. When you open up that next chart, really ask yourself, are you coding the true clinical goal of the encounter, or are you just coding the loudest symptoms? Honestly, the answer to that question is exactly what separates an amateur from an expert coder. Keep decoding, and I'll catch you in part 43.